Now I think we'll move on to a very important session, that is smile. I think first of all, I would like to invite our chairperson, Professor Tithial sir, Dr. Mahipal Sachdev, Dr. Rupal Shah, Dr. S.P.S. Grewal, Dr. Jodh Mehta, Dr. Arul Muzi Varman, and the moderator for this particular talk, along with me, Dr. Sonu Goyal himself, Dr. Vardhaman Kankeria, and Dr. Safawadia from Gujarat. But to start with, I think we will have a one special lecture from Professor Dr. Secundo from Germany. He'll be talking to us about the corneal biomechanics in different type of refractive surgeries keynote. So I want Dr. Sonu to give the brief introduction of Dr. Secundo. Over to you, Sonu.
So, thank you, Professor Sikundo, for accepting our invite. And we are really sorry for those last minute glitches. So, let me introduce KP Professor Sikundo. Walter Sikundo is a university professor and chairman at the Department of Ophthalmology, Philipps University of Marburg, Germany. He has published more than 160 scientific papers in peer-reviewed journals, 43 book chapters. He has edited the first international book on smile, delivered over 700 presentations at national and international meetings. And what is more important, he has received twice the prestigious Leonard Klein Award for the German Ophthalmological Society for the development of new surgical procedures, among them the smile procedure that we are working on. And he's also focused on working on treatment of hyperopia and presbyopia, what shortly we'll have on our VisuMax platforms. So a terrific surgeon and a great guy. And yes, he's on vacations. Thank you so much for sparing time for us, sir. So he'll be talking on corneal biomechanics in different type of refractive surgeries. And can we have the chair and the moderators? And meanwhile, I'll request the AV guys to have Dr. Vardhaman Kankeria, Dr. Kamal Kapoor, and Dr. Sudarshan Kogar to please let them be in. Probably they are in the wait list.
Okay. Thank you so much, Dr. Sonu. Do you want me to share my screen, or will you? Okay, I'm going to share my screen.
You can start sharing your screen, sir.
Yeah. This time we're going to rely on Spanish internet connection. As was mentioned by Dr. Sonu, I managed to get on holiday for the first time for the last 1.5 years due to this pandemic. It's a great feeling, you will experience in some time, when this terrible time is over, how nice it's just to travel somewhere else.
You're waiting for that, sir.
Yeah, absolutely. Now, obviously, in those 15 minutes, you'll be able to see a few things you already saw at other meetings, but I promise I will also show you some new experiments we did, particularly in terms of hyperopia treatments using the SMILE procedure. And as you might know, for the last 5 to 6 years, we've been collaborating together with the group of Farhad Hafezi from Switzerland, who are well known in checking biomechanics in keratoconus corneas and other corneas. And actually, it turned out to be a very fruitful cooperation. We already published 5 papers and just submitted another one. Now, the background is quite known to every one of you, so I just make it short. I mean, you remember going back to 2013, then Reinstein and Randleman, they published a paper showing that basically SMILE procedure, after myopic SMILE, it's important now, the myopic SMILE procedure leaves the cornea stronger, with better biomechanics as compared to, let's say, femto Lasik or PRK, and it was a purely theoretical work. On those days, we decided, okay, we want to prove it using experiments. And then again, I was looking for a group that knew how to check the biomechanics, because remember, when you do hysteresis, you do these core things, it's just a blow onto the cornea, but it's not what's happening when we experience keratoconus, because keratoconus and keratoconus, you have the forces from within the eye, not from the outside of the eye. And this is a device that's been developed by Hafezi group, particularly by Dr. Kling, who is part of his group, or used to be part of his group. This is their device, how they test the corneas. So we go to the human corneas. Initially, we did some porcine corneas, and then we moved to human corneas. And this is a paper that was published in 2018, where we had 22 fellow eye human corneas of 11 donors who were not suitable for transplantation. Obviously, we had to remove the epithelium because of those post-mortem corneas. Otherwise, the femtosecond laser does not work well. And we also checked the ultrasound pachymetry, which is quite important when you check the biomechanics. And basically here you see what we did. We did obviously a very large treatment, because remember, those corneas are very swollen. These are post-mortem corneas, and we use large zones. It was basically -10 diopters. For LASIK surgery, because there's no reepithelialization, I use fibrin glue basically to seal the flap, as it would your epithelium of your normal patient would after a successful LASIK surgery. And that's what turned out, and that's what we published in 2018. It was a huge difference between the SMILE treated corneas and the LASIK treated corneas. Now, when you look at this stress strain relationship, and you see this is LASIK and SMILE is way out superior, and it was highly statistically significant. Was no surprise to all of us, because this is what we thought, and it's just another type to show it. And basically, it gives you the idea that SMILE is 1.47 times stiffer than femtosecond LASIK for the same amount of treatment performed. So the next idea is, because you remember all of us, when we have those corneas that, wow, don't look very good, we say, why don't we just do PRK? Because it's safer than doing femto-LASIK. And the question is, what about SMILE? Already there are a couple of cases that were published also from India, where we saw that actually doing SMILE on sort of, not very good corneas might not be a good idea at all, because they also can develop keratoctasia. So here again, similar setting, 13 donors, 26 fellow eye human corneas, same refraction, but again, right eye of the same donor received a PRK treatment, the left eye of the same donor received a SMILE treatment. And here are results, and the results are somewhat different. So when you look again, SMILE, now SMILE is not the line, the curve above, SMILE is the curve below, and PRK is the curve above, which means, there's a strain-stress relationship appears to better for PRK. Obviously, we also checked the statistics, and it turned out there was no statistical difference, but at least there's a tendency that PRK might be a better choice in terms of biomechanics. Now, since there's no statistical difference, this always was published, but honestly speaking, now, if you imagine, if we would have had, instead of 26 eyes, perhaps 126 eyes, perhaps we could show a statistically different results. And now I come to something that's really new and hasn't been shown, I think only showed once at the Chinese meeting. Because now, since we're all moving toward hyperopia treatment with SMILE, and I can assure you at this moment it will work. We finished the multi-center study. I know the results are great, and we're in the process of submitting in for approval. And then thereafter, we will be able to show and publish the results. But what I already did, I think, okay, I realized that hyperopic SMILE is not an easy procedure. It's not as simple as normal SMILE procedure. Why? Well, because you have large, huge lenticles. These lenticles are sometimes 8.6 because we need the transition zone. The transition zone for hyperopia is very, very important. When you might think of one of my very, well, not first, but one of the earlier publications where Marcus Bloom and I, even in 2010, were attempted to do a hyperopic flex. And we realized we had a huge regression. So thereafter, I basically gathered all the old folks, from Zeiss, who used to develop ablation profiles for hyperopia treatment. And hyperopia treatment with mil 80, mil 90 is very successful. And asking, what is the keys to success? Why it doesn't work? And they say, well, the transition zone is too small. Okay, fair enough. So we created a new profiles, and it was published in 2016 and 2018. And I did flex. I did over 100 eyes with flex, and it worked very well. Now, flex was easy because you lift up the flap. The problem with a smile is that you have a very large, let's say you have a 6.5 optical zone, then add to those 6.5 optical zone 2 millimeters of transition zone, it will give you a lenticle diameter of 8.5. Now again, the hyperopic eyes are usually have small corneas, so there's not much room for the cap. So you end up with having not a transition zone, sorry, the corridor, the clearance zone where you can get with your hook in order to be above or below the lenticle, which is sometimes like 0.1, 0.2 millimeters. So now we need to see, what are the advantages of such a more challenging and demanding surgery. Well, later on, once we publish the hyperopic data, you will see that at least, this is my interpretation, is that the refractive data are more stable, but they're not much different from femto LASIK. And this is why I already decided to look at the biomechanics, because, well, perhaps the biomechanics are better. So we had 26 fellow eye human corneas, again, with 13 donors, the same setting. Instead of -10, we went to a very high correction, the highest sort of possible of +6 diopters, with a 7 millimeter zone, which gives you the largest bulk of tissue you remove. And again, a flap of 110 microns and cap of 120. I remember when I submitted the paper, the review asked, why 120 and 110? I said, well, this is because what I do in real life. When I do hyperopic LASIK, I tend to use 110 micron flap. And when I perform SMILE, my standard setting is 120 microns for the cap. And as I show you, the transition zone is 1.8 millimeter. What's important is when we do hyperopic SMILE, unlike in hyperopic LASIK, you've got to have some minimal thickness in the center because it's absolutely impossible to remove a donut. This is, our ablation profile would be otherwise a donut. So in order to get a lenticle, actually you need to have some thickness in the center. Now, in those thousands and thousands of eyes operated on, I only had one severe complication, and it was a very early case of hyperopic flex where I had a buttonhole, because initially we were thinking that 10 microns would be enough, but they were not. Okay, so this time we decided to use a 25 microns. As a matter of fact, Dr. Pradhan and Dr. Reinstein already published a paper on hyperopic SMILE from Kathmandu, and they even used 30 microns. But then again, if you have a thicker center, it also increased the amount of tissue at the periphery. So those are these things to be thought of, and then I'll show you the results. Here we are. The stress-strain relationship with a median of 14.8 megapascal versus 11.6 megapascal, and elastic modules, when you look, they're not much of a difference. So it was absolutely no statistically significant difference. In even, unlike, I show you with the PRK in myopia, I don't think that if I would increase the number of eyes tested, I would get different results. So basically, whether it's hyperopic SMILE, hyperopic LASIK, in terms of biomechanics, we get very similar results. Now I come to the conclusion of my talk, and we'll have hopefully 1 or 2 minutes to discussion. So for myopia, it is like we all know, SMILE is better in terms of biomechanics. It's roughly 30% stronger than femtosecond LASIK for the same correction. And as you increase the correction, the difference even becomes larger and larger. So it makes much sense to offer SMILE surgery, particularly to young patients. This is why I offer SMILE surgery, female, or those ladies who are in an age where they might probably get pregnant. But SMILE has no advantages over PRK in terms of biomechanics. Obviously, it has other advantages, nice comfort, whatever, no pain. But in terms of biomechanics, so if you do have sort of queer cornea, you don't like it, it's quite okay to say, and this is what I do. Nowadays, instead of going for SMILE, and obviously no femto LASIK whatsoever, let's do PRK, okay? But for hypermetropia is different. So how do we explain that there is no difference between SMILE and femtoLASIK, because we all sort of got used to it? Well, first, as I said, there's a much larger bulk of tissue removed due to the central 25 microns, as opposed to donut-shaped ablation when we use excimer laser. Now, again, the tissue we remove in hyperopic ablation is the tissue at the periphery. And remember that the mid-peripheral stroma is the strongest part. It's the anterior, but not anterior in the center, but anterior and mid-peripheral. Now, also, in order to to adjust to get to the lenticle the easiest way, I did not use a 2 millimeter incision. I used 4 to 5 millimeter incision, because otherwise one gets in real trouble to get the lenticle out. So it is a larger opening. And well, who knows, cap per se might be a barrier of the elastic behavior of the remaining corneal stroma, because theoretically, we enlarge the surface of the cornea because we steepen it up. But here we have a strain of the cap which cannot be stretched forever. Now, if you think of your LASIK cases, you do a hyperopic LASIK, you really have a large gutter at the periphery. Why is it? This is because we enlarge the surface. Here, the cap could be like a strain not to move the cornea the way we want it to be. And perhaps, and it's something that should be shown in the future, it might be even better to have a central corneal, or not corneal, central lenticular thickness of more than 25 microns, perhaps 35, just to create some space within the cornea in order for the cornea to adjust to the new shape. So those are the things I wanted to share with you, and I'd be more than happy to discuss it. So in conclusion, while the myopic SMILE is a way superior to femtoLASIK in terms of corneal biomechanics, it did not show any difference for hyperopic corrections in our in vitro studies, but in vivo studies might change it. Once approved, hyperopic SMILE will have to be studied thoroughly in order to figure out the advantages and disadvantages of femtoLASIK. I hope, perhaps less dry eye, because dry eye is quite an issue, particularly in hyperopic ablation. But, this is, how we're going to see what's going to happen then. All right, thank you so much.
Thank you so much, Dr. Secundo. It was a fantastic talk. And I just wanted to have a couple of questions from my side. Actually, I've been doing the SMILE and also Presbyon for the last 8 to 9 years. But a lot of my friends been, I think, doing SMILE monovision for presbyopia, but I prefer to do Presbyon. But since we are not accessed with the hyperopic license in India, except for a couple of centers for trial, so you have got a large experience with the hyperopic SMILE. So have you done hyperopic SMILE in presbyopic? Those patients are hypermetropic with the monovision trial. What is your results?
I did indeed, because the majority of my patients were rather low hyperops. I think the part from Marburg, I did 96 eyes for the of 374 eyes we treated in this last study. I did 96, and I had a mean spherical equivalent of plus 2.2, and I would roughly say 1/3 I did basically monovision, and it works wonderfully.
Yeah.
But whether it's just because it's presbyopia, I mean, if you think back, before we had Presbyon and all the other things, and we did monovision for hyperopia, it also worked very well because it induces spherical aberration and it gives you the depth of focus. But yes, it worked very well. As a matter of fact, the head nurse of my operating theater, she's got it. And I really envy her, because she can thread a 10-0 nylon and I can't see it. I have to look under the microscope, and she does it without glasses. And this lady, she's 58.
Thank you so much. Professor Tithyal is here. I think he's the man who has written the textbook of SMILE, who is doing a high SMILE surgeon. I want
that.
Professor Tithyal.
Thank you, Kudlu. Wonderful lecture, Dr. Walter, and thank you for your inputs in our book also. And I just like to have one query solved from your side, both for a smile as well, a myopic as well for a hyperopic smile. What is your experience with patient with a slightly higher cylinder? Have you included cylindrical power also in hyperopic corrections?
Yes, the hyperopic was both sphere and cylinder. We do tend again to undercorrect slightly in very high cylinders. It works extremely well for sort of, two diopters of cell, works very well. And I can assure it because at the moment I already started to write up the paper, and obviously because there's so many authors, it will probably take some time, to get agreed on the paper, but then we will submit it. And the data are right. They're not brilliant, they're not bad, they're right, and extremely competitive to the femtosecond LASIK.
Good, that's very good.
Walter, really good to see you again.
Good to see you too. I wish I could see you in person, Rupal.
I know. It's been such a long time. I just wanted to say that even if the results are the same as we had seen even in the earlier ones, the flex results that we did, simply not having a flap is an advantage, because that itself is going to allow you to relax in terms of the post-op complications that are possible. So even if the results are the same as femto-LASIK, I think SMILE still is the way to go. Also,
I'm sure people also will use it, but I think what my recommendation will be after the surgery, that hyperopic smile should not be given to a novel smile surgeon.
yes.
Hyperopia, should be given to those who've done enough myopic smiles. Similar, as you remember, as you and I, when we started flex, pseudo smile, and so on, because it was, even to my surprise, it was more difficult just because it's huge lenticle. You get such a bulk of tissue out of it, it's enormous. Yeah.
Professor Walter, what is the hyperopic range that we are looking at?
Well, in the study, we went up to +6.
+6. So I think refractive stability, number one, and maybe less incidence of dry eye could be two added advantages as
well, I must admit, we did not look at the dry eye characteristics in this study, but the refractive stability, at least this is my opinion, when I said it looks a little bit better than what we have with femtosecond LASIK. But I hope, as Dr. Shah just pointed out, I just hope that the problem with the dry eye will become perhaps less of an issue, because this is a real trouble with hyperopic ablation as you compare to myopia treatment. Yeah.
One more quick question, a last quick, and then we move to the next one.
Yeah. Yes, thank you. And I think Professor Sukhandu, we really enjoyed your pioneering work and the talk. So now, my actually question is regarding generally on the place of smile in your clinic versus like now when you have access to surface ablation, femtosecond LASIK, and smile. So, like basically, what are the patients you are currently choosing for surface ablation and femtosecond LASIK? Like your predominant procedure, of course, is going to be smile. But what are the patients that you are choosing currently where you would like to do a surface ablation and a femtosecond LASIK procedure?
Well, again, surface ablation for me are those the corneas sort of I don't like. Corneas like don't feel very comfortable, and I use everything, even if I don't do not trust entirely into Corvis. I also use Corvis in other things to feel comfortable. If I don't feel comfortable, I would still turn to PRK, just because it's what my results show. For normal ablations, particularly myopic ablations, I always use SMILE, roughly till the age of perhaps 45. And from there on, it becomes Pre-Beyond. And as a matter of fact, I showed at one of my meetings in 2016, 80% of my laser refractive surgery was SMILE, and the rest of the femto-LASIK. Now, it's only 60% SMILE, and the rest femto-LASIK, because once I entered the Pre-Beyond era, and particularly in our population is much older than your population. So I recently looked at the numbers. The mean patient age in my clinic is at the moment 42. So Pre-Beyond is a real issue. So the next step for me, and I already discussed it even with people from Zeiss, is moving, as it was mentioned, just recently moving towards the press beyond smile, because this is the age of population. But also, again, we do know that the visual recovery in those age 40 plus with smile is slower than with femtoLASIK, whereas young patients really enjoy smile. Also, we developed our own nomograms, which we published for Press Beyond, because I do Press Beyond in a slightly different way than it was shown by Dr. Reinstein. Reinstein uses 6mm zone. I don't like small zones. I use for myopia 6.5mm zones. That once you use a larger zone, the nomograms do not work. You've got to work out on your own nomograms, and that's what we did. And again, what we also figured out for Press Beyond, you've got to have a separate nomogram for the dominant and non-dominant eye. And I'm sure Dr. Krishna will be able to support my statement. But this is what we do. Young patients smile, older, over 40, more toward femtoLASIK, and then once they reach the presbyopic age, femtoLASIK as a Press Beyond procedure, and PRK for corneas that are not good, but it's 3 to 5%, not more than that.
Yeah, that's great. Thank you very much.
Yeah, we have with us Professor Rohit Shetty, who has been doing a lot of research work on the different refractive procedure. I welcome Dr. Rohit. I think 1 or 2 comments from the Dr. Rohit. Unmute, Rohit.
Thank you, sir. Thank you, Professor Sikando. Nice seeing you. One of the things which I want to say is the smile and LASIK depends on how the wound healing happens, has the same type of biomechanical stability when it reaches after 6 to 7 months. Lot of in vitro studies and in vivo studies are completely different. However, PRK still stand the test of time as being the strongest in all forms, whether you do in vitro and in vivo studies. And now at this point of time, we are doing some work on collagen orientation itself. And we feel that there is significant change in how the collagen is protected in smile, but that should not give us that armor saying that I would do smile on a patient who is suspicious. That is just to tell us that it will prevent you maybe from regression or help you remodeling of epithelium gets much better in smile. But I don't think it gives you that armor to do it on even a slightest of suspicion. And quickly, the second point I want to tell you is the genetic, we are sending this paper to the IOVS this month. The genetics of healing of smile and LASIK is completely different. That's why the type of ectasias you get in smile is not the same type as you get in LASIK. In smile, sometimes you get ectasias in a near normal looking corneas, because the complete gene pathway of healing is different. It's a very, very interesting concept. I don't want to take anybody's time here, but I just want to say that healing is driven by genes, and genes are different in different processes. That's why your risk factor of developing ectasia in smile is completely different from developing an ectasia in a LASIK patient.
Thank you so much, Rohit.
Thank you, Rohit, for that wonderful input.
Yeah, let's go to the next talk. None other than our own man, Dr. Sonu. He'll be talking about the basics of smile surgery. Dr. Sonu Goyal is a member scientific All India Ophthalmological Society, and also who has helped so much to get this session.
So the basic aim of designing this course was to bring in the basics, people who are willing to start their refractive surgery, who are into the process, and then gradually build up to a process where you can refine the best of the best. So I'll be just talking on the very basics of smile surgery, basically addressing for people who are interested in starting the smile surgery, what smile is all about. So we know that this is how in smile the incision can vary between 2 to 4 millimeters, as against the standard LASIK, where we are almost going 360 degrees, just leaving a hinge of 4 to 5 millimeter. So the key steps in smile surgery is a lenticule cut. If you see in the green, then you have a lenticule side cut, a flap cut, and a flap side cut. And then you extract this lenticule from a small tiny incision, which can vary from as low as 2 millimeter to 4 millimeter, depending upon your experience and your expertise. So Smile, the Visumax, or the all other platforms on which we can do this lenticule extraction is not affected by the ambient room conditions, as in the Lasik platform, where you have to maintain a particular temperature or a humid conditions. There is no controlled airflow and the plume which is necessary to be removed, and there is no laser calibration or a fluence test which can impact the results. And what is more interesting is the time taken for the overall treatment, whether you treat a -1 diopter or -10 diopter, remains the same, because it is just basically the lenticule thickness that we are working on. So LASIK basically cutting a flap, transferring a patient from one OR to the other OR, where you have a femto and a laser platform, opening of the flap and tissue ablation. As against in Smile, you just need to have a lenticule cut and the lenticule extraction. So the optics in all these femto platforms basically work on a very small spot diameter. They have to have a very high depth accuracy and a single pulse energy, which is very, very small. So the typical Visumax, no financial interest, works on less than 300 nanojoules, low spot energy. It's a 500 kilohertz and a very small spot spacing, which gives you an excellent cut quality without any side effects of DLK and TLS, and accurate focusing small spot for well-defined incisions. And that gives you a very good, clear extraction of the lenticule. So this is what we have been doing now. And for the interest of the beginners, the patient is once docked, and this is what you see, the lenticule cut. The patient keeps on looking at the tracking light. This is the side cut, and then this is the cap. And then you have a cap cut. So moving from 4 to 3 and then maybe to 2 millimeters, you need to identify the two planes. One plane beneath the cap, the other beneath the lenticule. You go underneath the lenticule first. A very smooth dissection. And then maybe the second part of it under the cap. I usually leave a knuckle on the left side, separate 360 degrees, and then what my friend Gaurav has taught us, wonderful hydroexpression technique. I don't fiddle. Advantages, yes. As you see with the flap cutting, the nerves, the anterior plexus is gone. So with Smile, there are less chances of dry eye. It is believed that it gives you much better biomechanical stability, because the anterior stroma is one which is the strongest, and Smile basically involves the posterior stroma. And as we have seen by the talk Dr. Walter has expressed, 31% more biomechanically stable as against the FS laser, and almost comparable with PRK. So this is the biomechanical stability. One very interesting and very important thing that enchants me of Smile is even if you have an imperfect centration, since the lenticle shape is almost same, there is the decentration doesn't induce aberrations or doesn't affect the quality of vision, as against with the excimer lasers, where you can have aberrations whenever you have slight decentration of the ablation. So with the experience and your beginning, even if you have a slightly decentration, the quality of vision is usually not affected. One very interesting paper by our own Dr. Kyal came up with the evaluation of 100 consecutive eyes undergoing Smile. And the most important, they concluded, was the learning curve of Smile is surgically challenging. And basically, it was the lenticule dissection and the extraction, which they believe is the most difficult step and leads to multitude of complications. So at times of lenticule dissection, you can have the stromal damage, anterior cap tears, side cut tears, partial extraction of the lenticules, and at times you can have a completely retained lenticule. So for beginners, for surgeons who are beginning the practice, I think they should stress more on the lenticule dissection and where complication-free extraction of the lenticule can be undertaken. A lot of complications can still occur. You can have suction loss, you can have black spots, OBL, You can have cap lenticular additions, you can have retained lenticule, you can have cap tears or side tears, and then at times you can have epithelial defects. All these can be addressed in the slow learning curve. Suction loss, smile is quite, adjusting in this way that whenever there is a suction loss, the most critical is when you are more than 10% in the lenticle cut till you reach the lenticle side cut. It is only in that stage you need to convert to a femtosecond LASIK. Otherwise, the machine restarts and you can continue with the same cone and continue the lenticle extraction. So in that way, it's quite forgiving whenever you have a suction loss. So retreatment options now with Circle software can be converted. A cap can be converted into flap, and then any residual error, refractive error can be corrected. So gone are those days when we were thinking of not able to treat those residual refractive errors. So to conclude, it's a highly predictable, refractively stable procedure. The recovery is very fast, leads to little or no intra and post-op pain. The Circle software enhancements can be done. But what we demand from the industry is the treatment for pure cylinders. Hyperopia, we have all heard from Dr. Walter, Dr. Mahipal. Yes, it has to be in, and shortly it will be in. OCT guided, that's what I have a wish list. If we can incorporate an OCT and an OCT guided separation can be done, so we'll be able to solve those problems or retain lenticles, if any. And cyclotorsion registration can be undertaken to have accurate treatment of the cylinders. So thank you very much.
Fantastic, Sonu, for an excellent talk. I think whatever is there in your mind, you demanded. These are the things has to come in Smile platform. We'll go with the next talk. None other than we call in India the mother of Smile, Dr. Rupal. So she'll be talking about my evaluation of Smile. Over to you, Rupal, madam.
Thank you.
Welcome, ma'am. Mother India.
Are you able to see my screen?
Yes, ma'am. We can hear you and see you.
Thank you. So at the onset, I would like to thank the AIOC and for organizing such a superb way. And also, I thank the moderators for giving me this opportunity. I'm going to be talking about my evolution of Smile. And I have a pleasure to say that I was the consultant for Carl Zeiss Meditate for having to evaluate this particular procedure right in its infancy, and I could to some extent contribute to its development. So let's talk about the beginning, and we are very glad that Professor Secundo is here with us today because he along with Dr. Marcus Bloom from Germany commenced the first clinical studies in 2006, and they published the results for their clinical study. They first performed 250 eyes in their respective clinics. They showed that the procedure was feasible, was accurate, but that the visual recovery was too slow to compete with LASIK. And at Center for Sight NVLC, we started studies in August 2008, having the base of this first 250 eyes done in the world. In our initial eyes, we were extremely surprised by the accuracy of the results. And at 1 year, we found that more than 95% of our eyes were within plus or minus 0.5 diopters. Another thing that surprised us was the surgical ease and the lack of corneal edema and haze. Of course, since no one had performed single incision Smile before, we needed to even design some instruments to perform it, but everything was not rosy. We did notice a long visual recovery period, and that very first few cases of flex that we performed. And as you can see, the scanning pattern is totally different. We started from center to periphery, followed by a side cut of the lenticule, and then from periphery to the center for the anterior cut, followed by a full cut. And nowadays you would not be able to see this because flex is no longer really performed. You can then open the flap, expose the bed, but you can see how nicely you could separate everything. At that time, we were tentative because we didn't know how sticky or otherwise it would be. Once you have a flap opened, you can find the lenticule, go underneath and peel off that lenticule or separate it out. And then wash and put the flap back. So this procedure I wanted to show because I don't think that in any other time now we are going to be seeing this procedure. But this was like a good stepping stone because we understood how the separation was occurring and what was happening inside. And we could also do some experiments in order to try and improve the results. We initially started with flex like this. It involved creating a corneal flap and removing the lenticule like I showed you. But within our very first few eyes, we moved to smile. So within a month, we started doing first pseudo smile and then immediately smile. And I'm happy to say that I was the first person to do one incision, single incision smile in the world. We first published our results of 50 smile eyes in the Journal of Cataract and Refractive Surgery in January 2010, which was again the first publication of smile with a single incision. Obviously, the slow visual recovery was a matter of great concern, and especially since the origin of the slow visual recovery was not known, it was really we were very uncomfortable with it. So we tried several explanations and theories around it. We conducted several interventions to rule out these theories, and this is all that we tried. We tried putting steroid drops in the interface to rule out interface edema. So we did it in one eye and not in the other. Since we had this opportunity to do flex, so we would open the flap, put the steroid drop, put the flap back, and in one eye we did that, the other eye not, and compared the two eyes, and we didn't find any difference. We also tried putting bandage contact lens in one eye and not in the other to see whether the surface remains smooth, didn't help. We tried to do PTK on the undersurface of the flap and the remaining corneal surface to make the corneal surface smoother. Again, this didn't work well. And so we kept thinking and we kept observing the ones where we were getting good results the next day. And intuitively, we found that in some eyes, we could even predict that this person will do well the next day. So then we went back and looked at all the videos and we found that when the bubble pattern was particularly dense in the center, the visual recovery was poorer. And this led us to the understanding of the cause of poor visual recovery, which actually went a long way in the further developments. So as you can see here, the first pass, all the bubbles are fine, but then the bubbles start coalescing. So when the second pass occurs, it's going through a distorted media. This would then lead to, after the lenticule removal, a distorted cornea in the center. So in the scan pattern A, as it was happening before, we used to go from inside out, and you should notice that there is a lot of bubble pattern developing right in the center by the time the second pass comes and reaches that central portion. And it's very evident here in this video that already you see how many bubbles are getting developed in the center. So you can imagine how the center would be. It would be totally irregular. So we suggested a change in the scanning pattern, and Zeiss complied, and we did this particular pattern where we went from periphery to the center first, and then quickly from center to the periphery. And you can see that the bubbles have no chance to accumulate in the center, and therefore you can see a miracle. So while only 65% of the eyes were unchanged or gained vision at 1, and 83% and 94% unchanged or gain at 6 months, we jumped simply by changing the scanning pattern to 83 and 98%, and this was like a eureka moment. And therefore, the other improvements in visual recovery was quite logical. There was increase in the frequency from 200 to 500 kilohertz. We increased the spot spacing in 2012, and the improvement in laser spot quality. All this resulted in Smile today, which has visual recovery, which is similar or sometimes even great, is even faster than femto-LASIK. And in our practice today, more than 97% of the eyes reach best corrected visual acuity the very next day. And today, now I'm focusing on increasing surgical ease while maintaining the speed of visual recovery. I'll take only 10 seconds. The ultimate idea is to have a free-floating lenticule, as Dr. Tityal said, that has shown in his study, that it is the lenticular dissection which is the thing that can maybe have a not so good visual recovery in the very next day. So what we are trying now is to play around with the frequency, the spot spacing, the lenticule thickness, spot spacing in lenticular edge creation. in order to achieve a free floating lenticle, and that's what I'm working on right now. The remarkable aspects of SMILE, of the predictability, accuracy, stability, it's an aspect which has not really changed or changed very little, even though many aspects of the treatment has changed, which is better energy in spot parameters, different scanning pattern, higher frequency and better surgical technique. And today, more than 98% of all eyes are within plus or minus 0.5 diopters of the intended correction. So in conclusion, SMILE is definitely a technique which has come of age. It shows across several studies that it is much superior to even femtoLASIK, and it has become for many high volume surgeons the technique of choice to treat refractive errors. And already in the world, more than 3 million procedures have been done. And thank you very much for the time.
Thank you, madam. Thank you, Rupal, madam, for a wonderful.
Thank you, ma'am.
And I think we'll take the question in the end, madam. So to continue with the SMILE, now I invite our friend Dr. Gaurav Luthra. He'll be talking about perfecting SMILE. Gaurav Luthra doesn't require any introduction. He is one of the superstar, very good phaco-refractive surgeon from Dehradun. Over to you, Gaurav.
So,
thank you,
perfect
Dr.
surgeon, huh?
for your kind words. And it's a privilege to be speaking in this session. Thank you to the organizers, Sonu and you and AIOS for inviting me. I'll quickly share my screen. In fact, Dr. Kudlu has been responsible for me to start SMILE about 4 or 5 years back. And I was lucky to learn my first steps from him, Dr. Rupal, and a few other of my colleagues and friends. So, and learning the right way is, of course, very, very important. So perfecting your SMILE, I'll try to give you some of the pearls which I have picked up on the way and try to share them with you. So most important thing is that for those who are planning to start SMILE, I think it's a good idea to graduate from PRK or LASIK or femtoLASIK, because that sets you up for doing SMILE. I have seen some people, who started first thing with a Visumax. They did not have an excimer. I don't think that's a great idea, because to be complete, you should have a decent existing refractive surgery volume, because SMILE being very expensive, it may be difficult to break even. And also, as far as the technique goes, it does have a small learning curve, which you need to be, if you're good with femtoLASIK, it always helps. So Visumax alone may not be sufficient for a complete refractive surgery practice, and you may need for a few of the things, just like we just spoke about, hyperopia, high astigmatism, maybe customized laser corrections. It might still be required to have an excimer for now. I think the future holds much more this thing once we have hyperopia with us. So the Visumax is a wonderful machine. It makes excellent flaps as well, and of course does lots of other corneal procedures. And most importantly, it does for you a SMILE procedure. But as I said, that we might still need an excimer. In my practice, about 60 to 70% patients are very good candidates for SMILE, or even more, sometimes 80%. And then there are always those 10 to 20, because I also like to do surface ablations and I like to do occasional femtoLASIK as well. So the learning curve has been spoken about, and it's definitely much easier for those experienced with femtoLASIK. And I think you have to be patient, and in the first 100 eyes, you have to take it easy to start getting consistent results, because that's the time when the machine is growing on you, and you tend to understand the energies of the machine, and your dissection techniques are improving. The tissue handling is very, very important, because that is what gives rise to delayed visual recoveries. And with experience and less handling, faster procedure times, and better patient comfort, the first day wow factor starts coming out very soon. And as Dr. Rupal went through the history, I will not go through that. The first generation machines, people used to scare me when I was going to buy the Visumax, but I think all those fears are totally unfounded. The current generation machines are way ahead, and the Visumax has very good energy setting tweaks with minimal OBL, very good dissection ease, very good refractive results, and a wonderful wow factor. So I think for SMILE, I think the case selection, especially in the first few days, is very, very important. And that's the key to success with SMILE. And during the learning curve, it's good to avoid very low and very high corrections. So initially, I learned that, because the lenticle thickness will be very thin, and also maybe the refractive outcomes were not as perfect in the very small correction. So I avoid doing lenticles thinner than 40 microns, because you tend to have difficulty with dissection, and you can have a retained or a left behind lenticule. And very high corrections as well, if you're planning to start minus 10s and all right in the beginning, may not be a great idea, because you need to tweak your nomograms as well. And I would initially avoid astigmatism over 1.5 to 2 diopters. Of course, today I'm doing corrections of 3 to 4 diopters as well, because you gradually learn how to tackle those. And gradually one can increase the range of treatments, and of course later on the full capabilities of the machine can be used. In fact, it's wonderful to even make flaps which are super thin. So if you're doing corneas which are borderline and you want to have maximum amount of stroma to ablate, you can make flaps of even 80 to 90 microns. Of course that requires experience. Again, I think preoperative evaluation, it's the same as LASIK or PRK, and good topography. This is what we do, but of course every clinic would have their own nomograms. We do epithelium mapping, we do an eye trace and a dry eye workup, and always a retina exam. And our exclusion criteria would be the same as LASIK. Now, this is very, very important for everybody to understand. Many people initially thought that with SMILE you can get away with good biomechanics and start doing corneas which may be suspect or thinner. I don't think that's great at all. I use exactly the same criteria for excluding patients for SMILE as would be with LASIK. And the last and most important thing, very good counseling and chair time with the patient is very, very important. Today, this is how, this is a little bit in fast forward, of course. And a good SMILE procedure would be, I think Sonu has already shown how it would happen. I don't have to repeat it, but this was one of my patients who operated few weeks back. I would dissect the deeper plane first. So I don't like to hold the eye with any kind of instrument. I like to let the patient fixate. Of course, initially he may find it difficult because of the OBL, but and yes, it does look violent right now because it's a little bit in fast forward. But usually the patients are very comfortable when you're not kind of trying to hold their conjunctiva and you don't see any spots next either. And then the deeper plane can be dissected. And then of course, just like Sonu did on the left side, I'll leave a small island which I'll break last. And while I prefer to do hydroexpression, but often nowadays I tend to just deliver the flap like the lenticule like that. And then I like to watch the interface because some surgeons don't like to. It's your choice. So going on, I think why we came to that hydroexpression is because sometimes with forceps there are 2-3 things that can happen. If you have to do a kind of dissection to remove the lenticule which has not been fully detached on the sides, or if you have a very small, so beginning you should never go for a 2 mm SMILE. Start with maybe 3.5 mm or something, and then gradually as you become very experienced you can come to smaller incisions. There is no heroism in going with a very, very small side cut in that sense. And you can end up with a lenticule with a cap tear. I had to borrow this video from one of my colleagues, very old video, yet it delivers the message that forceps and the quality of forceps, and in fact, I would like to show you here that many times it's this point on the forceps which can actually catch hold of the, cap, and it can cause a tear because it'll just, as you, open and close the forceps, it can just catch hold of the lip of the SMILE wound, and that can cause all these complications. So this brought me to innovate and start doing hydroexpressions. I'll take you to the last part of the surgery. Once the dissection is complete, you can just go with the lenticule is fully dissected now, and you can just go inside with a gush. This is a specially designed hydroexpression cannula which I've designed, which the shape is peculiar to the eye. And you can just with a small gush deliver the lenticule. It comes out really well. And some cases where the lenticule may remain attached at some points, again, it's very beneficial. You'll see here that as I do the hydroexpression, if you've had some small island of connection still remain, you can still do a much better job than you would do with the forceps or with any other technique that you use. So here we still don't know whether my lenticule is free, but as I put a gush of fluid, the most of the lenticule comes out. A small island here, but all I have to do now is hold this small projecting part of the lenticule and just nudge on it, and it'll come out. So it also defines where the connections remain because most of the thing will prolapse and it'll come out. Dr. Kulu, I don't see a timer, so I don't know how much time I have left, but if you'll tell me.
You're exactly in time.
Okay, so I'm almost done. I'll just go to one last video and then I'll be done. Sometimes there are patients who have very obese and they have eye movements, and with their breathing movements, their anxiety, their heart rates may be very fast. You can see in this patient that as I just engage the suction and the patient is having significant, in fact, it was right in the beginning where the patient, as I'm even fixating, you can see those movements of the patient. So very heavy patients, you have to be careful. And also some patients who are very anxious. Now there's a second patient here, which again, we are doing this, and some of these patients who are very anxious and they're having a strong bells, they may move like that. And then when during the cut, when you're having the cap cut and the deeper cut, you can have more movements and that can cause lots of complications. So most important thing is to keep talking to the patient. And with that, I think I'll stop here. These videos are of no point. I'll just come to my last slide. So SMILE is a wonderful procedure with good case selection, very good chair time with the patient, good counseling and building the right expectations and perfecting your technique slow and steady. There's no point jumping into all kinds of heroics with SMILE right from day one. and studying your results and modifying protocols, making nomograms for corrections. And with that, I think I'll stop. Thank you.
Thank you, Gaurav. Thank you. That was really a wonderful talk. And your hydro expression, I think it works very well.
Thanks, Sonu.
So KP, can we have the next speaker?
Next speaker, I think complication management in SMILE. We have with us Dr. Gitansha Sachdev. She'll be telling about her experience with the management of complications.
So welcome, Gitansha.
Thank you, sir. Am I audible?
Yeah. Slides are visible.
Thank you. At the outset, I'd like to thank the organizing committee for this opportunity. So my talk today is on the management of complications in SMILE, both the common ones and certain rare ones as well. So we all know that the Visumax is a femtosecond based laser procedure, because of which there might be an incidence of suction loss. The fact that the applanation is softer and the laser pass is longer vis-a-vis the femtosecond Lasik, it could probably increase the incidence of suction loss. Now, in all cases of suction loss following SMILE, the procedure can be continued with certain variations in the parameters. The only exception remains when more than 10% of the posterior cut, which is the refractive cut, is complete, and one has to convert to a femtosecond Lasik. Now, while doing so, it can be done within the same sitting, and one can use the same patient interface. Since you're using a small cone, the maximum diameter that you could get is around 7.9 millimeters. So the centration here is of utmost importance, especially in astigmatic corrections. This is a case of a suction loss during the cap cut. You can see that the posterior lenticule cut and the side cut have completed. This irregularly enlarging tear film meniscus is a sign of impending suction loss. The procedure can then be continued from the cap cut, and the remaining steps can be proceeded with as normal. Now, there are certain cases wherein the corneal side cut may not form well because of the tear film being excessive or the conjunctiva encroaching and interfering with the femtosecond delivery. One can use a surgical blade in order to open the corneal side cut and gain access to the lenticule. This is an uncommon or a rare case that I wanted to discuss, wherein the suction was unstable, but enough to let the femtosecond laser continue. You can see that there was a superiorly encroaching conjunctiva here, which had interfered with the delivery, subsequent to which there was no corneal side cut. So in this case, we used the Circle software, pattern D, and converted the initial cap into a flap, akin to the flex procedure. This was then reflected, the flap as well as the lenticule complex, and the lenticule was peeled from the undersurface. Getting the right delineation of the posterior plane first is one of the challenges in the beginning for a novice surgeon. Even experienced surgeons can have difficulties in cases such as very thin lenticules, like Dr. Gaurav sir had just mentioned, or cases of suction loss, or ones in which the femto delivery might be inadequate with patchy OBL. What happens then is one may get the posterior plane first, because of which the lenticule may remain attached to the overlying cap. The challenge now is to get the anterior plane. This can be done either with the forceps, as is shown in this case, or with a sharp-toothed instrument. Once this first area of separation is achieved, one can then continue the procedure as normal. Numerous signs, such as the white ring sign and the meniscus sign, have been described, wherein the position of the instrument vis-a-vis the lenticule edge gives you an idea as to where you are. What we practice clinically is something called the stop sign, which is nothing but a stop or a resistance to the lateral movement of the sharp-tipped instrument at the junction of the delineated and the undelineated areas at both the anterior and the posterior plane. This is a contrarian video wherein you can see that the surgeon has gone on for a posterior lenticule delineation at both attempts. You can clearly see the margin of the lenticule overlying the blunt instrument. And at the second dissection, you'll see, since it's in the same plane, there is no stop sign or absolutely no resistance to the lateral movement. Retained lenticules are visually important complications, especially when they're larger or central remnants. Now, these large ones can easily be picked up, be it either on a tomography or the AIOC, or even a simple dilated retroillumination. These should be removed at the earliest, because Later, they could result in fibrosis and scarring with certain difficulty in removal. But what do you do with these cases wherein you can see there's a irregularity and a steepening on the curvature? However, the ASOCT or the slit lamp does not delineate the lenticule well. So what we do is we publish the use of a wash with triamcinolone, wherein you can see that these crystals will beautifully stain the edges of the lenticule, which can subsequently be removed. The important caveats to remember here is to do a thorough wash after you're done, so there's no crystals left behind. One should spread out the lenticule, as in all cases with complications, and make sure that it has been removed in entirety, and the use of a preservative-free solution is recommended. Smile is biomechanically superior to Lasik because the superior and the mid-peripheral collagen is left intact. But as has been mentioned by the speakers before, the guidelines should not be different from that of Lasik because as of now, cases of ectasias have been reported even following normal corneal tomographies. Epithelial ingrowth would have a lower incidence as compared to Lasik because obviously the epithelial handling is lower. But this is a case where we saw a visually significant growth about 6 months post-operatively. You can see that even 6 months later, one can open the initial corneal side cut. We go on to scrape the epithelium and do a wash with mitomycin C. The use of the Circle software to convert this cap into a flap, which can then be lifted, has also been published. This unilateral fungal keratitis is an exceedingly rare complication, but the only advantage of the SMILE procedure here is that you can actually administer the antifungals into the pocket and allow a much deeper penetration, which is not possible topically. This is the last case. It's a sterile infiltrate following SMILE, which was noted about 5 days post-operatively. Now, how you distinguish it from an infective infiltrate is the fact that you can see a clear intervening zone between the limbus and the infiltrate. There's no epithelial defect. The eye was relatively quiet, no anterior chamber reaction. The only complaint was a whitish ring from the patient. So the patient responded very well to topical steroids over a course of months and attained an unaided vision of 20/20. So I'd just like to conclude that there are certain unique complications with SMILE, as there are with every procedure, but a meticulous planning and management can give you optimal visual outcomes. Thank you.
Excellent talk, Gitansha. I think you covered almost every complication, what can happen with SMILE, and even your management also, it gives a very good clue how to go about your overall management. So I think the time to invite the superstar in Indian ophthalmology, none other than Rohit, has done a lot of work on the research as far as the refractive surgery or keratoconus is concerned. I'm very much happy that he belongs to our own town. His village is quite near to my village. I'm really happy to be like I'm his friend. So over to you, Dr. Rohit Shetty.
Welcome, Rohit.
Thank you, sir. Can you hear me?
Yeah, loud and clear.
Thank you, sir. I'm going to speak about future of SMILE, but all the previous speakers have given a very beautiful talk on this, and Rupal ma'am had already given this talk. So I'll just go into very brief of what I want to discuss so that I don't overlap. The points here is, first is I go into these formats, the energies, cyclotorsion, circle, hypometropia, intraoperative, and future. If I go into this energy setting here, we are coming lower and lower on the energy settings. You can see that electron microscopy completely changes as you go lower. And also there is different spot sizing, and the size of the spots also, if you change, the quality of vision actually becomes better. And this has been shown in this study that, you know, your quality, the contrast, and all depends on your energy and also the way of spot sizing you're going to do. And this, according to this paper, and many people out here says, I mean, it's been told that this is one of the best energy setting with this spot sizing. Combination works very well as far as the quality of vision and the contrast is. So what I envision is more and more we're going to see different spot sizing and more lower energies to get the perfect outcome. Dr. Sri Ganesh and Sheetal Bar had given us beautiful insights into how they control the astigmatism, how they use their techniques. But what I see and what I've seen in a couple of new machines is it comes with a cyclotorsion control. So what the future of Smile is that it will have an inbuilt cyclotorsion control. You don't have to do a manual thing anymore. And I've personally been seen two of the machines which has it already. The Circle software, Gitangsha has explained. I'm not going to go deep into this. Basically, it's not just only on Circle. What I'm going to say is we'll have a lot of these unique softwares for rescue operations. For example, you'll have softwares in future where you can do smile on smile. Now we have to do a PRK if there's a regression. You'll have softwares to do retain lenticule. You'll have a software to change some parameters to make your flaps on the smile lenticule, on the smile post-smile patient. So I think the options are going to be multiple, and that's what I want to say in this presentation. Hypermetropia, there are a lot of nice papers coming out now which does say that the quality of vision and stability of hypermetropia is as good as you see in Lasik, which is very good because one of the major challenges of hypermetropia is the regression. And these are all early papers, but if they're able to hold it for some more time, I think it will be the best thing we can see. Presbyopia, people are now, this is a monovision paper, but by Walter Sicando and his group, but there are a lot of work happening on can we do a presbyopic kind of ablation profile or lenticule change on the Smile platform. Intraoperative OCTs, not many machines now are looking at it, but I'm sure the future will have intraoperative OCTs. The reason we know we want intraoperative OCTs built is that, if you're doing a corneal-based procedures, I'm not very sure of this, but I know the latest machine of Zemer has an inbuilt OCT in it. And you can imagine you're doing a DALC or one of the corneal procedures, it will really have a huge impact in the procedure. This is the intraoperative OCT pictures which I've taken. This is not from the Smile, but in case you have a machine, you have to go to a different microscope and do it. And imagine having it in your own machine. That will be the way to go, because Smile anyway, I mean, this could be an upgrade, but this is a wish list, what I'm saying. Inlays, we've heard a lot of inlay work again by Dr. Sri Ganesh and Sheetal, and over time, I think many people across the world have grabbed this and they've been using it as an allogenic implants. And there are companies which makes these kind of implants, and I'm sure inlays are going to be a major areas of how we're going to treat this refractive procedures. And this is from Susan Jacob group about her Pearl technique of corneal inlays, what she's used. Let me just take into some amount of future what we've been working around Smile domain. We published this paper about predicting. Predicting is everything. Every time you see a COVID wave, first thing we'll look at is of all the IITs. Every IIT will come out with their own predicting models. COVID has taught us a lot. One of the things it taught us is a good insight into immunology and good insight into prediction. This is an old paper 5 to 6 years back when we looked at predicting how much of biomechanical changes every procedure would happen. And you can see the dotted lines was of prediction. The sharp lines are the ones where we actually seen a change post-operatively. So we designed, this is the first simulation model in the world using the Corvus and the Pentacam. It's a software. It's a completely mathematical driven software and happens to be the first machine in the world, first software in the world. And 22 countries are already using it. And me and Dr. Prema started using it quite early. It was developed in our lab. What is important here is this will be part of your Pentacam or Oculus softwares in the future. That means that every time you feed in data, it will tell you, it uses a different mechanism of spring modeling. That's why it's in newtons and meters. It will tell you if you do a PRK, how much deformation. If it's on this side, beyond this green, that means there's a chance of ectasia. so that you can feed in your patient, and you can feed in his data. The simulation model will tell you what is the simulation strength. That means this particular one will be part of your diagnostic tool, and this will tell you exactly which procedure I want to do and which procedure to avoid. And this is already past the beta testing, and Oculus is in your future softwares. This will be part of it, so it will be useful to see how you can decide Smile or Smile Extra or any other procedure. For example, if your predicted change in corneal stiffness post-operatively is more than around 15 or 20 newtons per meter, then you can look at a Smile Extra. Or if it's less, you can even look at a PRK. So this is how it's going to change. This is how it's going to happen. We've been working also on the way the Smile collagen works. This is the PSOCT. This is the normal, darker the blue is healthier collagen. What's interesting here is that in the Smile, the pre-op and the post-op Smile after 6 months is exactly the same collagen. Pre-op of PRK and PR post-PRK same. But look at Lasik. The darker blues have come down and you see less of darker blues. That means that collagen polarization has changed. That means it has completely reformatted itself, which you don't see. It's amazingly beautiful images. Why do you need it? These kind of machines are going to be part of how OCTs are future. So Smile is not about technique, or Smile is not about a surgery. Smile is all about understanding how does your Smile procedure behave on the cornea? Will it progress? Will it become ectatic? Will it change? And these machines tomorrow will be the future of how it picks up. There's also a big challenge about, in COVID times, you've seen the power of PCR. And we also need all this in our refractive surgery. So is Smile. So we brought this kit. We've been talking about it, but now it's in the clinic. It is already manufactured. This is a kit. You just have to put a tear film and you can get all these inflammatory markers out here. Why it's important here is because you can help to identify many things which can be a potential issue of dryness, potential issue of neuropathic pain, collagen, haze, if you're doing a PRK, or any of these things can be done. And this is now not a research thing anymore. We have signed up with this company. This is the world leaders in manufacturing kits. They also manufacture all the pieces. It's in US. They manufacture the kits for many, many things. And these things can be brought out. And our aim is to keep this less than 1,000 rupees. And you can also look at the other VEGF and everything from the tiers. What I'm trying to say is all the new techniques on machines which are coming out with new ways of making the Smile better. But what I see future is not just looking at a new machine or a laser. It's also about predicting how strong a procedure is, looking at the new ways of new imaging, like new OCTs or intra-op OCTs, and simple identification of unwanted dryness and other things which can create a huge havoc in your practice. I thank Dr. Kudlu sir and everybody out here for giving me this opportunity. Thank you.
Thank you, Dr. In fact, I think I just wanted to ask you one quick question here, that these kits already available in the market or yet to available?
We were supposed to do it last year, but this year, but the company which makes the kits, which builds that kit, was stuck with COVID. But next year, yes. And we have already using it in our lab, in our hospitals and some other places. It takes 45 minutes to 1 hour for the entire report.
So do you really feel that, okay, some patients really wants to undergo refractive procedure? Pre-operatively, if you do this test, is it going to help?
Absolutely, because it's not just for dry eye, it's about epithelial remodeling. If you're doing an hyperopia surgeries and if you want epithelium is aggressively remodeling, then you know that it's going to have an havoc with your outcomes. And Dr. Sikando, Professor Sikando has a question.
Just a question. Do you consider stuff in the future, like for every candidate for refractive surgery, or do you envision this as, for those that are questionable? Sometimes those are the things cases where you think, shall I do? Perhaps I put an ICL instead. Or is it like, do you think it's affordable for everyone and it's going to be a standard, like with topography, and you do the immunotesting as well, or genetic testing?
Professor Sikando, if you ask me futuristically, in 10 years, everybody. In 5 years, maybe 50%. And maybe because the reason is, it's not only just for refractive surgery dryness. If you're doing a PRK, you have to really know whether it's got haze or not. There are markers in which I can tell you before you do a epithelial removal, what are the markers. So you can advise the patient or you can modulate your steroids. If you're doing a cataract surgery, a premium lens, will this patient come back to you 5 times in 1 month telling that he has pain or irritation? So you can pick this up early. It's just not for refractive surgery, it's for anything. And the same kit can pick up the VEGF in your tears and also predict the changes of your vascular status. Or it can even, my colleague has worked on VEGF in tears of an ROP baby. You can even, I'm also looking at VEGF, I'm looking at dopamine from the tears to predict the axial length of myopia. My colleague Jyoti has worked on it. So dopamine is a very important I would say hormone here, which if you more the dopamine, less is your axial length. That means that if your dopamine is good, and dopamine gets stimulated with sunlight, that's why the children need to be in sunlight to avoid myopia. If there are too many children in sunlight, it will reduce our practice 25 years from today, but by reducing the myopia. But sunlight and dopamine are a healthy marriage out there. And dopamine can also be big. That means you pick up any immunological parameters, you can just then add on. This kit can just keep looking at, now we have 8 in it. I can make it 40 also. But the testing time is going to be the same. And we want to reduce it to 30 minutes. Now it takes 1 hour in the lab. But by the time the patient finishes everything and comes back, he's ready. But that is a beta testing.
Thank you, Rohit. Any comments from Professor Tithial? Tithial, sir?
Yeah, what to comment? Rohit always been a torchbearer in research in this particular field, and we learned so much from his work. And I understand SMILE and any procedure, he rightly said, it is the procedure and the outcome is based on what modulation happening with the corneal tissue structures. That's going to modify the outcome of particular case. And whatever he's working on inflammatory markers for the last almost a decade now, it's given us so many things to understand and look into. In fact, many institutions would struggle to have a similar, labs to get into that type of investigative research. So I really congratulate Rohit for a wonderful work, and I hope that he keeps working for this direction. We get a lot of information from his work.
Thank you, sir. I just want to tell one thing, because Dr. Krishna Prasad was there for the presbyopia also. When you do a presbyopia, the most important thing is not the machine you use, how the epithelium heals. If the epithelium actually heals by 20 microns, your entire presbyopia goes for a toss. And what makes the epithelium go bad is your ocular surface and the inflammation. So imagine, we always concentrate on machines, technologies, lasers, but we always, what Professor Tithial perfectly said it, it's the healing which is more important than your lasers and energies. Your lasers and energies, even if the little way of body can heal, but if your healing becomes bad, everything messes up.
Thank you so much, Rohit. I think any other comments from any of our panelists or any question to Professor Rohit?
Thank you, Rohit, for that very inspiring talk. We can now move on, KP, to the next talk.
Yeah, Dr. Jodh Mehta, the next talk is by Dr. Jodh Mehta from Singapore. He is around.
Science and Smile, Dr. Jodh Mehta. I think he's logged in, is it?
Yeah.
He did log in.
Yeah.
Dr. Jodh Mehta, is he around? Okay. So maybe we can just check with him. And KP, we can now shift on to the session of phakic IOLs. And we have our own Dr. Kamal Kapoor, who will be talking on workup for phakic IOLs. So Dr. Kamal Kapoor is a prolific phaco-refractive surgeon, sharp sight, and a huge volume phakic IOL surgeon. Kamal, are you there?
Yeah, I'm there. Can you hear me?
Yes, boss.
Okay. I think I must thank you, Sonu, Dr. Krishna, Dr. Tityal. I think it's always a treat to listen to Rohit. You know, he comes out with these beautiful ideas which are so original. And, you know, a lot of times you feel like scratching your head that how could he even think of something like that? But I guess that's what Rohit is. That's what Rohit is all about.
That made you lose all your hairs, huh?
Yeah. Okay, so I'll be starting my session. Actually, I was having a lot of trouble logging in, but Sonu helped me. Then I finally contacted Namrata and she let me in.
You can start sharing your screen, yes.
Yeah, so I'll be starting with my screen, workout for phakic IOLs. And as we all know, phakic IOLs, you know, they've been here for a long time and, you know, they've been here and they've done all. I've actually seen patients with extreme powers of -36, cylinders of 14 diopters, done piggyback phakic IOLs. So I think phakic IOLs have actually proved their mettle over time, and they're actually shown what they are capable of, and they are always there for our rescue. But the problem is in the workup. There are some salient observations which I've picked up over the time since I've been doing these phakic IOLs. And I have no financial disclosure with any of the products I'll be talking about. There are various options of phakic IOLs available in the market. Mainly, I'll be talking about ICL and IPCL, though I've used most of the other brands in the market and I've used them in good, decent numbers. Now, there are some relative and absolute contraindications in phakic IOLs, at least in my opinion. Whenever you have a myopia, which is, you know, more due to the cataract, corneal dystrophies, anterior chamber depth less than 2.8. Yes, I have done lesser than 2.8, but yes, I think that the cutoff should be 2.8. History of uveitis, healed uveitis, posterior synechiae. Very important thing is that having a lens rise more than 600 microns. And I've noticed when the lens rise is more than 600 microns, even in spite of having a good angle or a good open angle, you can land up in trouble. Patients with shallow angle glaucoma, angle pathologies. There are a lot of times if you've not done a UBM, it makes sense to do a UBM because I've had 2 patients where there are some retroiris cysts in these patients and we couldn't figure out. So that's the time we decided to get a UBM in our organization. History of retinal detachments in the past, shallow RDs. Keratoconus is very interesting. In keratoconus, a lot of times we will have a lot of deep anterior chamber.
Kamal, sorry, yeah. Kamal. Your share screen, have you done the share screen?
Yes.
Yeah, but
the slides are not there, Kamal.
I have. My screen is shared.
No, probably you're not
shared.
I can see you.
Okay, I'll just restart again. Just give me a minute. I did share the screen. Just for the sake of repetition, I guess. There I go again. Now can you see my screen?
No.
Can you see?
Yeah, now we can see. Yeah.
Okay. Because I did push the button.
Yeah.
Okay. So there we go. Now can you see the screen?
Perfect, Kamal.
Okay. So there we go again. Workup for phakic IOLs. Again, just for the sake of repetition, I've tried my hand at different kinds of situations with phakic IOLs. Extreme situations, high powers, high cylinders, corneal scars, perforation repairs, a lot of these patients. So helpful tips which will help us to actually plan the right outcome with the right patient, selection of the patient and deciding the outcomes. I have no financial relationship to disclose for any of the products I'll be talking here. There are various options available in the phakic lenses and I have a large experiences with IPCL and ICL both, though there are many other products in the market. And I would say that the best would be to, mind some features here. Whenever you have myopia, which is apart from the axial myopia, corneal dystrophy, anterior chamber depth which is less than 2.8 millimeters, of course, you can get away with the other little shallower anterior chambers also, but yes, it needs a lot of practice and a lot of experience to do that. History of old uveitis, posterior synechiae, lens rise, again, I've realized over time, if the lens rise is more than 600 microns, we'll be talking about this in detail as we move along, is a little bit of a slight contraindication. Iris cyst, I have 2 patients, as I did mention, which were having an irregular vault, and I would try and dial the phakic lens in, and I would again have a shifting of the phakic lens and a tilt. Then I did a UBM to realize that there was a iris cyst, so I had to expand the lens there. History of shallow RDs or retina detachments, and keratoconus. As I was saying, keratoconus is an interesting situation where you will have a steeper cornea in the center, you will have a good anterior chamber depth, but the angles are not that good. So it's always a great idea not to proceed with in a patient of keratoconus if you have not done your gonioscopy. I think that's a warning. I've done a lot of cases and I've learned that lesson. There are different kinds of powers available. As you can see here, IPCL here is available in powers up to 30, and I've done up to -36. Cylinders, officially they're available till 8 diopters, but I've done till 11, and recently I've done a 14 diopters of astigmatism also. The sizes available are, so this will help you to plan for your patients. Now, these are the sizes available in the ICL. There are only 4 sizes available, whereas in the IPCL, you will have 13 sizes available. So that's why an IPCL has become my personal favorite, because I can fine tune and tailor it to the requirement of my patients. General, again, you can have up between 11.5 to 14 millimeters, as we repeat. Now, another good thing is that when you're working up for a phakic IOL in a toric patient, you need to have a very, very accurate, precise the keratometry and the astigmatic power of this patient. Luckily for us in IPCL, you have a customized lens which just needs to be put at 180 degrees, and it can get away with that. We've done up to more than 2,200 cases till now, and this is a brief summary of all the cases which we've done. Now, pre-operative, this is an important slide, though this is a very, very busy slide here, but there's a lot of information here. Very, very important point is we need to do a dilated acceptance of all our patients. A white-to-white measurement is important in all these patients, and especially if the astigmatism is more than 2 diopters. I personally do a vertical white-to-white also, because it helps me to plan the size in case I have a large pupil size. Now, pupil size measurement is very important. So I would recommend all the beginners to do a pre-operative scotopic pupil size, and also see what is the maximum dilatation achieved in these patients. There are some patients where the preoperative pupil size scotopic would be decent one, but it would not dilate beyond a particular point. So there you can get cut off, especially if you have a larger cornea white to white, because you need to put in a large lens. And if your pupil does not dilate beyond, let's say 7.5 or 8 millimeters, then you're stuck up. Keratoconus, I did mention, you have to be very, very careful. You need to measure your lens rise on your OCT. Keratometry readings, as I said, if they are more than 2 diopters of keratometry shifting, please measure the vertical keratometry also. Doing a gonioscopy always makes a sense in these patients, because you can land up in surprise with some patients. And of course, a specular microscopy in these patients. What are the practical breaking points which can happen? You know, if you've not done a good cycloplegic refraction, because in my initial cases, I had patients who were wearing -9 diopters of spectacles, and on an AR, I was probably refractive getting a 8.75. I did end up getting and correcting them for a -9, and I realized they were probably accommodating because they were wearing wrong power glasses. Similarly, large size resting pupils need to be mentioned in your file and measured, because you need a larger size optic. Here again, an IPCL comes to your rescue, because you can actually order large size IPCLs. I have done up to 8.5 millimeters of IPCL. Putting a pilocarpine, I personally avoid any kind of a myotic in these patients, because they make the vault shallow initially, and this vault will again go back to its normal within 3 to 4 days time. Watch out for the IOP peaks, especially patients. These patients are highly susceptible to be steroid responders, so they can have an IOP peak within first 2 days, could be detained viscoelastic, or they could have an IOP peak maybe after 5 to 6 days if they are steroid responders. Cycloplegic refraction is very important. Just for the sake of repetition, measuring dilated and undilated pupil is very important, and note down in your file. There are various methods you can use that. I use a dynamic pupillometry on my Cirrus machines to do that. In case you're using a caliper or an image-based infrared method, always use the outer limber line. You can use your autorefractor keratometer to do these. Yes, if your anterior chamber depth is 2.8, are you safe? I would say yes and no. look for angle anomalies, look for iris configurations, look for lens rise, look for keratoconus, because then you can land up in situation. Now, this is what a lens rise is. If you draw a straight line on your OCT diagram from one angle to another, the amount of microns the lens rises up from this straight line is your lens rise. So anything more than 600 microns, you need to be a little bit careful. So plan your vault slightly higher than you would. So probably going in for a higher 2.25 millimeter higher size than you would. Wide to wide measurement is one of the most important hallmarks of this situation. You can use different machines, but standardize your nomograms to whatever machine you're using. So I would not recommend any one machine. Whatever you're using, standardize it. I am personally very, very happy with Cirrus measurements. I've done more than 2,000 of cases using this machine. So as I just said, if there's a variance of more than 0.2 millimeter between both the wide to wides, recheck again until unless there is more of astigmatism here. Now this, I think after this, I'll just have the last slide. Now, in case you're planning a toric IPCL, this is a slide which I borrowed from Himanshu.
Please conclude.
Yeah, I'm just finishing. Last slide.
Really great. Thank you.
In case you're planning a toric IPCL, I would recommend go for a slightly larger size because these lenses would fit snugly and they are lesser prone to rotation. Thank you.
Thank you, Kamal. It was an excellent talk as usual. I think probably the highest numbers of IPCL in the world, probably you are the man might have done.
Thank you. Thank you.
That's Kamal. Just in continuing with the same talk, we have with us Dr. Himamshu Matalia. He'll be talking us about the getting the sizing right. Himamshu is a prolific phaco-refractive cornea surgeon from Narayan Netralaya, Bangalore. My dear friend, over to you, Himamshu.
Thank you, Dr. KP. Just give me a second. Okay. It's not allowing me to share the slide.
AV team, can you please help?
Yes, sir. Sir, please open your PowerPoint first, sir.
Yeah, my PowerPoint is open.
Then click on share screen, sir, which is on the bottom of your screen in green color, sir.
Yeah, no, that's what I'm doing, but yeah, now I got it. Got it.
Yeah.
Perfect.
Welcome, Himanshu.
Thank you. So, are you able to see my slides?
Yeah.
Perfect. Thank you very much. And I'm going to be very brief with my presentation. I do not have any financial disclosure, but upfront, I have to tell that my experiences with ICL and IPCL, so I'll stick to that. However, the principle still remains same for all these lenses. These are ciliary sulcus fitted lenses. Why we talk about sizing? Well, because we know that irrespective of whatever best hands, whatever we have, we still have cases where we have to explant ICL, IPCL. And in these cases, there is something which is related to the vault or the sizing of the ICL. When we talk about phakic sizing, most important parameter for the sizing is vault. Now, vault is nothing but we know that it's nothing but the back surface distance between back surface of the phakic IO and front surface of the crystalline lens. And the ideal vault is somewhere between 250 micron to 750 micron, depending upon the individual cases. But what happens if the vault is not accurate? What if the vault is very high? Well, in that case, there can be angle closure, there can be pigment dispersion, and there can be sometime rare endothelial damage also if periphery is touching the peripheral endothelium. Low vault can lead to cataractogenesis, and there can be rotational instability of phakic IOL. These vaults can be reliable based on what technique we use. Now, I use hydroinsertion. So there is no viscoelastic used during the procedure, whether loading or implanting the lens. Hence, the vault can be reliable a little earlier. But if you use viscoelastic, which is absolutely fine, then you have to wait till the viscoelastic absorbs. So if visco is in front of the lens, there can be falsely low vault. If it is behind, then it can be falsely high vault. The parameters which are very important, as Kamal was describing, which is one is AC depth, horizontal wide to wide, and power, of course. The interior chamber depth usually is analyzed using contact techniques like ultrasound A scan. In that, we have to detect the pachymetry, or UBM, or optical devices like IOL master, pentacam, OpScan, ASOCT, and those things. By default, cutoff limit for both the lenses is 3 millimeter, but sometime you can go lower also. We'll come to that later on. But beyond AC depth, you also should be looking at possibility of any angle anomalies and all those things. So get a good gonioscopy done, look for any peripheral cyst in the iris and all, and also look at the configuration of iris. As you can see from here on the right side, that iris can be flat configured, it can be convex, or it can be concave. And along with this thing, as previous speakers spoke about crystalline lens rise, which is very important. When you join these two lines between the edge of the iris, part of the lens which is in front it's called crystalline lens rise. Higher the rise, there are chances that you can end up with a low vault. Now, horizontal white to white by default is measured using digital caliper. Patient in supine position, and you go in the middle of the limbus. Again, there are a lot of debate which can be middle of the limbus, clear cornea to clear cornea. There's no clear answer to that because we are still going to put the same size lens there. I will come to that later on. However, please remember, different instrument can have significant variability in individual. Now, this is my own right eye, and you can see pentacam, IOL master, keratograph, eye design, everything has different white to white measurement. So which one is right? Well, the ideal thing is you should go with two methods. One method, whichever suits you, be consistently with that. And the second method has to be your digital caliper. Please remember cases like VKC where they have pigmentation, your optical methods can be sometimes faulty. So what I prefer to do is I prefer my pentacam where I do image inversion. And then what I do here, as you can see here, horizontal slit, and I do image inversion. And with the caliper, I measure myself the white to white. The same thing I feed in my digital caliper, and then I confirm on the patient. The advantage there is the digital caliper can have its variability, and to avoid that, you can possibly know exactly what white to white is. Now, but whatever we do, please remember, the lens we are putting in sulcus, but we are measuring white to white. Now, how does that help? Well, by default, we feel that horizontal white to white is 0.4 millimeter to 0.5 millimeters smaller than sulcus to sulcus. But that's not always true because there are enough studies which show very poor correlation between sulcus to sulcus and white to white. So you cannot always trust on that, but irrespective, we still have to believe one thing. Now, if you have certain UBM like quantile here, you can actually measure sulcus to sulcus also, and you can actually see the vault on ICL, there are simulated vault, and which can work very well. But does it mean sulcus to sulcus is best? Well, interestingly, that self has its repeatability. Just last week, I had one patient. I did sulcus to sulcus measurement and white to white, which was different. I went by sulcus to sulcus, and I had to expand the lens and put the lens, which was sizing absolutely proper according to white to white. So not always sulcus to sulcus also works. Coming to the trick of sizing, I'll give you the small concept here that a same size lens, if you put in a larger eye, you will have low vault. And the eye size, which is smaller, you will have high vault. Now, based on this thing, if you go by this, that this is with the 3 millimeter AC depth, I've calculated the lens suggested through the calculator. And if somebody's white to white is 11.7, well, the lens would be 13.2, which is 1.5 millimeter larger than the white to white. And even if it's 12.3, the calculator will still tell you 13.2, which is 0.9 millimeter larger only. So where do you think vault will be high? Well, of course, where the difference between the lens and the size is more, where vault is going to be high. Now, the problem is when you have low AC depth and your range is coming in the first part, that's where you can have higher issue of the post-op outcome. So please be aware that when such kind of cases you are dealing with, you may want to have decent AC depth. Coming to the calculation about the toric, here I'm taking the example of IPCL. Now, what if we have 11.65? The calculator will tell you 13 millimeter. and 11 point.
Dr. Himanshu, I'm so sorry. Just a gentle reminder. You have only a minute to go. Thank you.
So if where would you have low vault? Well, we know that where the difference is less, the vault will be low. So in such kind of case, instead of going by what calculator tells me, I go one size higher. And what it does, it gives me rotational stability, and the vault will increase by 60%, which is like 150 micron. So with this thing, I end my talk, and thank you very much for your patient listening. Thank you.
Thank you, Dr. Himanshu. I think, as usual, the fantastic talk, I think, made most of us doubts clear. So we are end of this part. I think I welcome our Chairman Scientific Committee, Dr. Partha Bishwas, who has been tirelessly working for getting this such a wonderful program. I think I am the one person who is part of his committee. I could able to always feel that how could able to get this many numbers of talks, and also to include 18 halls and getting a lot of international faculty. I welcome Dr. Partha Bishwas. Sir,
thank you very much. Thank you. Thank you, KP.
Our international faculty, Dr. Sekunda, also here. I think you can just have a word with him.
Hi, Dr. Sekundo. Welcome. Welcome to India.
Thank you
virtually,
very much.
But we want to see you physically next conference at Mumbai. You have to come. You have to come. And today you must give your word for that.
And as long as there's no infection in the world, I'll be fine.
Don't worry. You come and the infections will go.
We're so fed up with this webinar type of style, you know, because what's missing is really the discussion. And actually, you gentlemen do it very well. At least there's some discussion. I witnessed webinars and web conferences where it just goes boom, 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 you know, and there's absolutely no interaction. And it's what it's all about, you know, interaction.
Thank you very much. Thank you.
But actually, despite being on vacation, he's with us.
So Dr. Partha Bishwas is a prolific phaco and even phakic surgeon. I have seen him talking almost 10 years before about the introduction of phakic lenses. Today, he'll be talking about the complication management of phakic lenses. Over to you, Dr. Partha.
So welcome, Partha, for our refractive subspecialty program.
Thank you very much. Thank you. Thank you, Sonu, and thank you, Kudlu. In fact, you know, whatever they are telling about me, actually the spotlight should be on them, because they are the ones who have designed this program, got all the faculty together and everyone together along with Dr. Sukando. And we are so happy that all of you are here. I could just hear the last part of Himanshu's talks, and as usual, Himanshu is wonderful. So we'll just go on to the phakic IOL complications and how do we go about it. I'm going to have you through a few videos, and we will just see these complicated situations and how to take care of them. So this is a very, very unusual situation, but it can be usual in a person who is doing his ICLs maybe for the first time. And this is a learning phase in which the ICL has not been loaded well, and that is the reason why the loading of an ICL is very important. It has not been loaded well, and look at that, it has got stuck. And if it gets stuck, it's very important that it should be taken off very, very gently. And once taken off gently, it is a usual implantation, and it can go on very well. These ICLs are extremely pliable, extremely flexible, and they have stood the test of time. And they are so compatible to the human eye that we are really fond of them. However, the indigenous the phakic IOLs are also in place and do a good job as well. Let us look into the next video, and this is a video in which, again, this is a patient that is not so well dilated, and look at that, not so well dilated, and thereby the dilatation is so important for an ICL, at least for the primary surgeon, somebody who is doing surgery in his first few cases. And this was a case in which, because of a mid-dilated pupil, we had a little bit of difficulty. But it's important that even if it does not dilate, you have to be extremely gentle with the iris, and one has to be extremely gentle with, because this is a phakic eye. It's not an aphakic eye where you're putting in the lens and you're working with a small pupil. So here, very, very gentle handling of the iris. Otherwise, in this part, the iris is going to come out. So why did it happen? And that's something that we need to talk about. It happened because possibly not only was the viscoelastic in the anterior chamber a little more than what was required. There was a mid-dilated pupil, a little too much of the viscoelastic, and possibly that went behind the iris. And when such a thing happens, then one needs to burp out the extra viscoelastic before putting in the ICL. And that is something possibly I did not do. And there was popping up of the iris from the main port. This can happen also from the side ports in a mid-dilated eye. So suffice it to say that the dilatation should be as optimal as possible, and then only the ICL can be placed atraumatically into the eye. Now let us look at this situation, and here is an eye in which we have. So what has happened here? The ICL is stuck in the main wound. The patient actually jerked, and this is what happened. And you can imagine my situation in this point of time, my heart in my mouth, and the ICL is possibly flipping upside down. And if such a thing happens, it's going to be a prolonged surgery. If it has to be removed, the ICL getting removed, and the ICL again going in the right way. So here I'm supporting the ICL and trying to reason where in the main port it had got entrapped. And once entrapped, this will not unfold out exactly how you want. So you need to support it and see to it that the unfolding is proper, does not go upside down. Because once upside down, then this ICL cannot be floated the right side up within the anterior chamber. It would need to be taken out, again reinserted, and then once the reinsertion is there. However, the removal can usually be quite gentle, and that same ICL atraumatically can be replaced back again. So it's not so difficult a problem. However, it's a problem that needs to be taken care of. The ICL exchange. Now, this was a patient in which we had a toric ICL in place, and it was not of the right diopter. We needed to explant it, and you can see that I'm placing in an amount of high molecular weight viscoelastic, and this is usually not done, but in this case we will do it because we want to protect the corneal endothelium as much as possible. Now, while explanting the ICL, you'll notice that definitely there's handling of the iris tissue, and more than what would be when we are placing in an ICL. However, the importance of grabbing the ICL in the right plane and then hand over hand technique with an atraumatic forceps and removing the ICL out of the anterior chamber. Removed atraumatically, but look at that, the pupil has gone down. So now we place in the right ICL with the right diopter, and this time again the folding is good. I'm lucky that the pupil has dilated well and the ICL is going into the anterior chamber quite well. However, once the ICL is in the anterior chamber, you can re-inject the viscoelastic, and once the viscoelastic is re-injected, then the pupil dilates also because of the amount of intraocular pressure raised momentarily because of the viscoelastic. So it is important that not too much of fiddling is done in the anterior chamber, and obviously the lens should not be injured either. Now here I'm going to present a particular patient, and this is a patient in which it's a longish video. I'll fast forward it. Now this is a patient in which we had this cataract after the ICL. Now what happened is we had placed an ICL and everything was doing well, and suddenly this patient developed retina detachment, though the patient did not have any other peripheral lesions in the retina pre-operatively. And so After developing retinal detachment, the patient underwent, okay, I think that's the buzzer coming in, okay, and the patient underwent retinal detachment surgery. In 2 months, there was this amount of cataract, and with this cataract, that means that there was possibly a lens touch. So we have to remove the ICL. There was an amount of after the removal, what we could see, there was fibrosis there, and to do a good capsulorhexis had become quite difficult. We were trying to milk out the amount of fluid from this intumescent lens, and then as we did the rhexis, now what we saw is the rhexis ran out. So it ran out, in fact, in 2 places. I'm fast forwarding it because of the paucity of time. But there was this thick plaque in the posterior capsule, and that means that there was the lens touch and it was converted into a plaque. So we had at least a PC that was okay. Okay. So I'm just about to finish it. So what we do, we place in the intraocular lens, then make a stab incision with the MVR knife, and then do a posterior capsulotomy with the vitrector. So this done, the IOL is nicely in place, and that ends the surgery. Patient had 618, 624 vision, and 10 and 12 vision after surgery. Thank you very much for your patient hearing.
Thank you, Dr. Partha. Thank you for being on time.
Thank you for a wonderful talk.
Thank you.
Nice time you came into our session. We are also happy as a part of scientific committee, sir. So
Thank you, Dr. Partha, for that wonderful talk. So any questions for this session?
I think
so. We'll be looking to the time constraints. We should now move on to our next session, session 5. And this session basically talks on, we have keratoconus, smile extra procedures, intacts, and the complications. So can we have the chairs on board? Dr. Rajesh Fogla, I think he is logged in. Dr. Rajesh Fogla, Dr. Himanshu Mehta, Dr. M.S. Ravindra, Dr. Satyamurthy. And the moderators for this session would be Dr. Susan Jacob, Dr. Ratnesh Sharma, and Dr. Divya Reddy.
So before that,
hi, Dr. Fogla.
Dr. Titial, anything to say the previous session, sir? Our chairperson.
No, I'm absolutely delighted. This session went so beautifully. I think one of the best sessions till of the day, and especially Partha coming towards the end makes the thing look so good. But truly speaking, we had a terrific presentations, right from our international guest Walter Secondo and Rohit putting all the spices on this session. Wonderful interaction, and I think a lot of thing to gain, not for people going to join us, but for us also. It was a teaching for everybody. And congratulations to Partha, and especially 2 guys sitting here, Sonu and Kudlu. Wonderful job. Wonderful. Terrific. Very nice to see.
Sonu and Kudlu, can I take leave if you don't mind?
Yes, sir, sure. We know. Thank you for sparing time and reaching us. Thank you so much, sir.
Thank you very much.